We did publish our correlated data about the pharmacokinetics and pharmacodynamics. So far, because two factors, the nature of the therapy and potentially sample size. So far, and all the biomarkers could not, so far the CAR T-cell therapy, Tecartus, has ignored all the worst prognostic factors. That means it caused the same amount of response rate and duration response in low risk and high risk patients. And I think the skew towards the CD8 could be a factor of the prior ibrutinib, and we are in still is a very small sample observation, and we need more time and more samples to validate this potential scientific finding. This trial is designed to only enroll patients with BTK pre-treatment. 80% of the patients are refractory to prior BTK. Only in about 10% of people are intolerant to BTK. So the majority of the patients are refractory or relapse after or while on or after BTK therapy. So they are refractory to BTK. So the response rate of what I stated, 87% overall response rate, and the ORR, I mean the CR rate of 60% applies to those people with the prior BTK therapy because that's the nature of the study. The most frequent toxicities actually is cytopenias. The cytopenias, all the adverse events reported to in the clinical trial are regardless of their relationship to started therapy, because as I explained before, this population in this clinical trial ZUMA-2 is a fourth line therapy with CAR T. So they have treated all those patients were treated. The median patient were treated with the prior other therapies, chemotherapies. They could induce cytopenias, and so cytopenias, including neutropenia, anemia, thrombocytopenia, are most common. But those related to the CAR T cell, most common ones are hypotension, hypoxemia, fever, and infections, and those are adequately addressed in the clinical trial, except about 3 patients who actually had a severe side effect. But the majority of others did very well. Their median time to CRS and the peak, around median time is very quick, about 1 to 2 days. CRS with a main effect, and it peak at around a week. And the neurotoxins usually start with about day 5 to day 7, peak about day 10 or day 14. This is totally consistent with the other CAR T cell products. So I think this, again, the benefit and risk ratio is very favorable. So this CAR T cell therapy, the other ongoing clinical trial is the Juno CAR T cell clinical trial with the CD19. And the difference between the two products is that the KITE product used the co-stimulatory molecule of CD28 versus 4-1BB utilized by the Juno product. Although there's some comment floating around saying that 4-1BB generally is less toxic than the CD28 product, but we cannot definitively answer that question unless there's a head-to-head comparison. And because the population difference, the product preparation difference, and because many factors are not identical, we could not compare directly the toxicities across 2 different trials. So I'm not able to definitively answer that question because of a lack of data. But there's people have generally felt that they are both very good trials in mantle cell lymphoma population.